Good afternoon, everyone. Welcome to the fourth session of the National Commission to Address Racism in Nursing's fourth ECHO series. This series has a focus on health equity. Whether you've been involved in previous ECHO sessions or are new to this space, we are so excited for you to be here today and hope that this interactive learning series is a place for you to find guidance and support in your journey. This program is brought to you by the National Commission to Address Racism in Nursing, a multi-organizational collaborative of leading nursing organizations examining the issue of racism within nursing and motivating all nurses to confront systemic racism. This is an 8-part series. You can earn 1.5 continuing nursing education units for attending today's session. Please stay to the end to complete your evaluation and receive the CNE certificate. Today's topic is barriers to achieving health equity. Before we go over our ground rules, we wanted to quickly orient you to some of the features of the new iEcho platform that we are using. Please do not use the Submit Feedback button on iEcho platform. We will put the link to the session evaluation in the chat at the end of the session, and it will also be sent to everyone by email immediately following the session. You will only receive a CNE certificate by completing the evaluation sent to you by one of our team. You can review session materials within your iEcho account in the Content section outlined here in green. Presenters will upload their slides and any other relevant materials here for you to use. There is a Conversations tab found within the Discussions tab circled here in yellow. This is meant to be a place where you can engage with other participants in the series. Please note any questions directed to ANA staff or any other time-sensitive issues should be sent via email to commissiononracism@ana.org. And also, if you're having trouble finding any of the features, please email us. We also wanted to note that we have had an overwhelming response to this ECHO series. That's a great problem to have. But consequently, we also have larger than desired breakout groups. Please bear with us. Although this is a great problem, it means that you will need to be patient with our incredible volunteer breakout group facilitators and the other participants. Please use the raise hand feature and be recognized. Keep your comments concise or place your comment in the chat to be part of the discussion. This will lead to a positive experience for all participants. So let's pay attention quickly to the ground rules so that we can learn how to engage with each other. Note that we will be turning off the chat during the didactic portion of today's session, and you will still be able to message a co-host directly if you need to. This is a brave space, and we know that discussing racism and health equity is difficult and can be uncomfortable, especially by those directly impacted. Discussions such as these can serve as a trigger. We ask that you maintain respect for everyone joining us today. Please stay on mute until it is your turn to speak. Listen intently and respond thoughtfully. Be present. Limit any background distractions and multitasking. Please take advantage of the virtual features available via Zoom. We encourage turning on your cameras and using the chat box feature or raise your hand to communicate with the group, but please remember to mute your microphone when others are talking. Also, respect participant privacy. We do not disclose names or any other sensitive information. If you share a scenario involving a patient, please do not use any personal information on today's call or on any of the ECHO sessions. And as always, feel free to message us at ANA ECHO if you have any technical problems during this call. So now I will turn the presentation over to Dr. Anna Valdez.
Thank you so much, Dr. Francis. Let me pull my slides up just so that everybody knows. My cat is sitting here looking very mischievous. So I'm working from home and hopefully he won't misbehave. So thank you very much for joining me this afternoon to talk about barriers to achieving health equity. This topic has been discussed several times in Project ECHO, and so I do encourage you to go back and look at other sessions because this is such a large topic and complex. I could easily do a semester course on this. I'm going to focus specifically on racism in nursing being a barrier to health equity, right? So we will focus on racism, particularly education that nurses get, and also racism denial within nursing. So first, when we talk about health equity, it's important to have an idea of what that really means. So I wanted to share two concepts. I had the opportunity to co-author a concept analysis on health equity, which is published in Nursing Outlook. And we came up with the definition that health equity is the fair and just opportunity for all people to achieve their full health potential without variation from personal characteristics, historical oppression, and societal influences. And that is an open access paper. So I did include it for you guys in the resources. Also, just so you know, as any typical educator, I always change my slides a little bit at the end when I'm preparing. And so you may see some slides that are different or slightly different than what is in the slide deck, and I will update that when I'm done. Now, I can't talk about health equity without talking about Dr. Kamara Jones. Dr. Jones is a physician and public health expert and a foundational scholar on health equity. And she said that achieving health equity requires three components: valuing all individuals and populations equally, and that there are no invisible, undervalued, or disposable people; recognizing and rectifying historical injustices, and providing resources according to need, not equally, but according to need, with the focus of health equity being not on everybody being treated the same, but people being treated in the way that they need to be to achieve optimal health outcomes. So when we look at health inequity, there are a number of social drivers that result in health equity. And some of the ones I think that are really pertinent to what we'll talk about today are discriminatory laws, policies, and practices, some of which were very blatant and harmful in the past, but have also evolved and are still present, oftentimes in more subtle or evolved ways. And you can get some of this information from the Future of Nursing report that recently came out. That's what reference number 2 is. And then medical and scientific racism. I think that most nurses are not aware of the way in which healthcare has harmed people of the global majority for centuries at this point. So I gave you 2 references, both of which are really excellent books to read. One is Medical Apartheid by by Elizabeth, it's Washington is her last name. I'm blanking on it. And then also Under the Skin by Dr. Linda Villarosa. And those are both cited for you. And then also False Biological Beliefs in Race-Based Medicine. I read an outstanding book called Fatal Invention from Dorothy E. Roberts. She has several excellent books that I think are so applicable to healthcare, but I really think Fatal Invention should be mandatory reading for all nurses. So I encourage you to read that. It really helps to understand how race was created, why it was created, and how we continue to harm people in medicine because of false beliefs and this idea of race-based medicine. And then social and environmental injustices. So currently in nursing, if we are focusing on health and what we are teaching is really focused on the right side of this, where it says current public health practice. And we're really taught, about 90% of what we're taught in a pre-licensure nursing program is around disease and injury. So it's focused on the outcomes that people experience from all of these upstream things that happen. Some of us in practice also learn about social determinants of health, And oftentimes we use those more as a blame and shame approach of looking at people and saying they're making bad decisions, they're making risky decisions, rather than looking at all the upstream things that cause adverse social determinants of health. So we're starting to look more now at political and structural determinants of health. And so this area that is in the circle is an area where we need to do a lot more education, because inequities are driven from other types of inequities. It's not that people are making bad choices. It's really that our system as it is set up in the United States advantages some people and disadvantages other people. And so my hope is we'll begin to see more of a focus on political and structural determinants, because nurses are powerful. We are the largest healthcare workforce. If we are engaged and united to address health inequities and to influence these upstream issues, then we can actually make significant changes in terms of health equity and health justice. But first, we have to understand it. And it's interesting because the Future of Nursing report identified that nurses asked for several areas of further education that they thought would improve their ability to be nurses: social determinants of health, population health, care of complex communities, care of underserved communities. And we have a real gap in our education around that. So often nurses are not being prepared to understand all of these things that are outside of the individual's control that are directly affecting their health. And until we begin to educate nurses about structural and political determinants of health, we'll continue to have this idea that social determinants of health are a result of bad choices, right? And not taking advantage of other choices. And therefore, when people are experiencing or facing health inequities, that's really their fault, right? And that's not the case. And we need to understand the ways in which we can intervene to improve outcomes. So whenever I talk about race, one of the most important things that I like for everybody to understand is that race is a social and political construct. There's no such thing. This was made up in the 1600s. Race was made up very specifically to deny privileges. Particularly when we look at people who were kidnapped from Africa and enslaved in the United States, when people who were enslaving folks would assault enslaved women and produce offspring, they needed some kind of way to not have those children have any rights to land or anything else, right? And so there were laws like you are what your mother is, or if you have one drop of Black blood, that you are classified as Black. And we've seen race evolve, right? For example, Irish people were not considered white initially. And Hispanic people have been an ethnicity for a long time because people in Spain wanted to be identified as white. And so it's all been made up. But the reality is that while race is very much made up, it is also the result of it and the intent of it is racism. And that's incredibly prevalent and real. And it's something that people are experiencing every day. So when I talk to nurses, the things that I've really identified within nursing as being the biggest barriers to addressing racism and also addressing health inequities is our educational practices, how we are responding in practice, and a anchoring bias that racism does not exist. So in terms of education, there are still a lot of false biological beliefs out there. A study was done in 2016 that originally started with the lay public, right? To assess whether or not people in the United States believed false biological things about Black people in particular. And the two things that they looked at were that Black people have thicker skin and that Black people experience less pain than people who identify as white. And so with the general population, more than 50% of people continue to believe those things, right? And those were things that evolved out of the enslavement of people, for us to be able to justify the atrocious harms that were being caused. But they've continued to be believed, and in part that's because we are not dispelling those beliefs. So then they decided to look at medical personnel, and so they looked at medical students and medical residents, and more than 50% of them also believe that Black people experience less pain and that they have thicker skin. And then when they applied some cases for them to work through, they found that people who were racialized as Black had inferior pain management, took longer to get a diagnosis than people who were racialized as white. So we continue to have these false biological beliefs that, influence the testing we do, whether that is looking at GFR, whether that is looking at pulmonary function, and they are made up in harming people. Also, nursing school perpetuates stereotypes. If you look at our textbooks, even textbooks published this year, they are rife with examples of stereotypes, biased language, and biased concepts. In fact, this year with my med-surg students, I gave them extra credit to identify, when we did reading in the chapters, to identify biased language, harmful concepts, and identify what should have been written there. In every single chapter, we had stuff to discuss. We also have a lack of structural competencies, which I talked about a little bit, understanding those upstream issues that are resulting in inequities. And I think that our focus on cultural competency has also been harmful and perpetuates racism. And while I think it was well-intentioned, right, that we need to take into account other people's cultural values and beliefs, the way that it's been implemented in nursing has been very harmful. So when you look at things on cultural competency, what you'll generally see, and I'm going to show you a picture, is racialized groups, or groups that people have categorized, which is wild just to start with. For example, if you look at Asian people as a race, the number of cultures and countries and languages that are piled together, and somehow we think we can have a couple of bullet points about people who have been placed in this category, and that tells us how to provide them with culturally informed care, is wildly unacceptable, right? And also, cultural competency has served to other people and to normalize white Eurocentric ideology, beliefs, and culture. And I'm going to show you how in the next slide. But we really need to shift to cultural safety, cultural rigor, cultural humility, understanding that we cannot be competent in somebody's culture, because culture varies widely. It's often individualized, right? It's not even just population based. And so we need to approach culture and the caring of people who we don't have as much experience with a lot of humility and respect, and make sure that people are being treated with dignity. And cultural competency has not achieved that. Education also now requires a lot of self-awareness and motivation, because we are not getting a lot of the education we need to be equity-minded nurses in nursing schools. And so when you get out in your practice, you really have to choose to do this work and to study, because a 1-hour implicit bias test and education is not going to give you the tools that you need to disrupt bias, to be able to address racism in practice. And then in practice, we have a real issue with racism denial. And I'm going to show you some of the things that nurses say to me and talk to you about those. And I think we have this anchoring bias that racism is not a problem in our profession for a number of reasons, which I'll talk about. We also have this challenge with willingness to take action. I did a study with my friend Lisa Wolf and colleagues looking at bias in emergency nursing. And we had over 1,200 emergency nurses respond, and every single one of them said that they witness or experience bias on a daily basis in the emergency department. And we also did focus groups, and every single one of them said that they don't directly address bias or racism. So if they see it happening and they think that's what's happening, they'll try to help. Like they might say, Anna, let me get the pain medicine for your patient, or I can take this patient from you, or something like that, but they don't directly confront what's happening. We also have this interesting risk-harm tolerance when it comes to racism. As a nurse, none of you are going to let me walk into a patient's room knowing that I'm carrying the wrong unit of blood and infuse that. It doesn't matter if I'm like the manager of the unit, if I'm an informal leader, if I'm the most seasoned nurse on the unit, nobody's going to let me do that because they understand that I'm going to cause harm. But they will let me walk into the room with racist ideologies or having said biased things and knowing that I'm providing biased care. And that also significantly harms people and can kill them, right? So we have this interesting culture around bias where we tolerate that because we don't want to create conflict with our colleagues rather than directly acting. And then also being prepared to know how to disrupt bias. Most of the nurses that I talk to, when they talk about experiences that they had or they observed, and they say that they didn't do anything to disrupt it or to speak up, it's because they didn't know what to say or how to do that. So we'll talk a little bit about that as well. So when I talk about stereotypes and racist ideology being embedded in our education, this is a great example. So this book has been removed from the shelves. It was published in 2017. It's a very common foundations course book in nursing. And so you can see that this is part of their cultural competency approach. And this is looking at cultural differences in response to pain. Now, first, even the way these categories are written is harmful. Like, please don't call people blacks. They are black people, right? This is a group of people, not a description of skin color. But also, you know, when you look at some of the other ones, it's harmful. So if you look at this, you've got people categorized into these groups that include tons of different cultures, backgrounds, ancestry, values, a language, and we add a couple of bullet points. Now, in this case, the bullet points are really harmful. So like, I'll draw your attention to Black people. It says Black people often report higher pain intensity than other cultures. So what does that mean to the student or the nurse that's learning this? It means that Black people exaggerate their pain. And so when a Black woman is given birth in the hospital and saying something's wrong and I'm in a lot of pain, and her pain and her concerns are ignored and she ultimately ends up not surviving childbirth, that is tied to this type of education and language within our teaching, right? You look at Jewish people here. It says Jewish people may be vocal and demanding of assistance. Again, what does that mean? That they're just pushy and that their pain is over exaggerated and I can ignore them. But if you look at Asians, they'll say they might not ask for medication because they don't want to disrupt the nurse, right? So what does that tell me? I need to push meds with Asian people, right? So we see this in all of the books that come across to nursing. We have a lot of work to do to eliminate this type of language and perpetuation of stereotypes. But I also, when I say to you that cultural competency actually reinforces racism, I want you to look at this group, right? Look at the categories that are here. Who's not here? People who are racialized as white are not on this list.
Right.
So why is that? Right? They're not here on this list because in nursing, we have normalized white Eurocentric culture as what is the right or normal culture, and everybody else is other and different from that, right? And so that perpetuates that othering and racism because it is normalizing one culture or the dominant group. So when I talk about racism denial, I really found that this article by Dr. Evelyn Barbie. Dr. Barbie was both a doctorally prepared nurse and anthropologist, and she wrote this paper in 1993. So it's been over 30 years now, and it's still as relevant today as it was when she wrote it. And also keep in mind that when she wrote this, the word racism was not even being tied to nursing in most scholarly publications. I could only find a few. And my friend Lisa Wolf found this article and we were working on the bias in emergency nursing, and it just really resonated with me. So Dr. Barbie said that there are 4 attributes of nurses that really affect our ability to address racism. One is an individual orientation. So we see nursing generally as a dyadic experience between us and the patient or us and the patient's family. And therefore, if I have good intentions And I don't look at my patient as being different, or that I don't intend to treat them differently, and I don't see my colleagues doing that, then racism can't exist in nursing, right? And it doesn't address all of the ways in which racism permeates healthcare, not just at the individual level. And then we also have an emphasis on empathy. We believe as a profession that we are empathetic. And I think we have an anchoring bias that we are empathetic, which keeps us from being able to see evidence that we actually have a lot of work to do. Right. And even if you're empathetic, it doesn't mean that you are not perpetuating racism or causing harm or being biased in your care. I have done 2 studies recently that included a scale of ethnocultural empathy, one with nurse educators, one with emergency nurses. And in both cases, we found that nurses who self-identified as white, had less empathy for people from other ethnic and racialized groups than nurses who were racialized as Black and some other populations. And I believe that's because, we see life through our lens, and it's hard for us to see through other people's lens and perspective unless we're intentional about that, unless we're intentional about listening and understanding people who have different backgrounds and experiences than us. We also have a preference for homogeneity, and I think that's true of humans in general. But I think that that has led to us admitting students who are part of the dominant group and appear like the dominant group in nursing, and also people's ability to make it through nursing school and then be successful in nursing practice because they experience biases that nurses may or may not even be aware are there. My daughter is a doula and was an obese scrub tech for a period of time. She's pre-nursing. I'm super excited, but she worked on a labor and delivery unit. And the first day she came home and she said, "Mom, everybody looks the same." And I'm like, yes, well, nursing is 80% white identifying women. And she said, no, everybody looks the same. Their hair color, the way they wear their hair, everything is the same. And so we have this preference of homogeneity that we may not even be aware of. And that can cause us to favor certain students or certain nurses and have beliefs that they can be successful, or wanting to support them, where people who are different from us, we may not be doing that with them as well. And then we have this issue with conflict avoidance. I told you, so ER nurses are pretty aggressive. We're pretty aggressive as a whole, right, as a part of what we do. But yet none of them were willing to confront any of their colleagues about biased care. And there's a lot of reasons. People said they don't know how to do that. They're afraid they're going to make a mistake. They don't want to upset other people. But you wouldn't do that if you saw me working on the person's wrong limb, or I tried to not do a checklist in OR, or I was going to give something to the patient that they were allergic to, right? If a physician wrote an order that was contraindicated, we wouldn't do that. But yet we're willing to do it when it comes to bias and racism. So one of the issues that we have too is that we see racism over here in this right interpersonal category, right? And so we see racism as personal biases between me and another person, right? Where I have bad intentions and I am doing something harmful to that person. And so if I don't directly see that happening and I don't see myself doing that, it's easy to believe racism doesn't exist if you don't understand that there are many types of racism. And so we have internalized racism. That can be internalized oppression from dealing with aggressions and harms every day of your life and being told that you're less than or you're not as worthy. We also have internalized privileges that we may not even be aware exist. And then there are some people who have beliefs, explicit beliefs about superiority. And we have other people who maybe have beliefs about superiority but don't even recognize it. Like every time I see somebody who says a DEI hire when they're talking about somebody who is a member of the global majority, they don't even recognize that that's extremely racist. You're making an assumption that because of the amount of melanin in somebody's skin, that they are not educationally prepared or qualified to do the work. And we had this problem in nursing when Florence Nightingale colonized nursing, she excluded nurses who were melanated specifically because she said that they didn't have the intellectual capacity to be nurses, right? And that's wild and crazy, but it continues to be in and embedded in our practice. The word that most people get uncomfortable with, the most uncomfortable I make people is when I talk about privilege. And oftentimes that's because people don't understand privilege. When people hear privilege, they think that you have a lot of money and a lot of resources. And that's not what we mean when we're talking about racism. Now, certainly that plays a role, right? There have been all kinds of structural and political things that have enabled some populations to grow wealth and denied other populations. But I want to give you a really, really subtle example of privilege. So, you know, my dad, he's white and he grew up in the projects. When he was 12, his father was murdered and he had 11 brothers and sisters. They were extremely poor. So the first time I talked to him about white privilege, he was like, wait a minute, I'm really poor. I grew up in the projects, right? But he has all of these other things like the benefit of doubt, the ability to move freely in all spaces that people don't usually recognize. So I want to tell you a really subtle story. My mom is African American, and she raised me, so I was raised by a Black woman, and that's important to the context of the story. So I don't like to get up early in the morning, and I was traveling doing DEI education, and I'm sitting in the restaurant, and the restaurant was closed. I'm eating my breakfast, and this family came in, you know, young parents, both, you know, phenotypically white folks, with two young boys, and they just missed the cutoff by like a minute, and they're grabbing some of the fruit and yogurt, great, but they're looking for spoons. And I said, you know, the guy just went back into the kitchen, he'll be back out, he can get you spoons. And the woman walked into the employee only area where the cash register was and started going through all the drawers until she found spoons. And I was sitting there just like aghast, not because it was rude, but I was just so surprised that she would do that, right? And the reason is because my mother would never do that. Now, my mom's a professional, no doubt would be dressed professionally in this setting, but she would never go back there and open those drawers. And the reason is because no matter how she's dressed or what she was there for, there's a very good chance somebody would call the police on her and say that she was trying to steal. So that benefit of the doubt even is such a significant thing when it comes to racism. And then there's institutional racism. Those can be unfair or biased policies that result in inequities for some people and advantages for others. We see this really prominently in nursing school admissions and admission criteria. And then structural and systemic, all of those cumulative effects of things that have happened over generations that have benefited normalized or dominant groups, specifically in the United States, people who are racialized as white or identify as white, and excluded or harmed people, the global majority. And there are things like redlining, for example, that have contributed over generations to the inability to access good education, living environments, safe and healthy air, the ability to grow wealth in the United States. The number one way we grow wealth is through land ownership. So the other thing that people often bring up is reverse racism. And oftentimes it doesn't get addressed because you know, it requires some nuance to talk about this. So one thing I'll say is if you are racialized or identify as white, you can absolutely experience prejudice, you can absolutely experience bias, you can even experience discrimination. But to experience racism, there has to be the ability of the population that is being racist for you to be harmed on a significant level, not just on the interpersonal level. So I've got a short video, and I know, Sarah, that I am close to time, and I can go through the other slides quickly, but I do want to show this. So let me just stop sharing and bring it up. I did test the volume, but if somebody could let me know right away if they hear the volume or not, that would be great. This short video is from a comedian, so it is meant to be funny, but it is also very poignant. So I'm not poking fun at anybody, don't intend any harm. We just want to talk about the elephant in the room and why reverse racism is not really possible at this point in time in the United States. So hold on one second, I'll bring it up. So this is a stand-up by Amir Ramad. I think it's really very poignant. If somebody could just let me know if you can hear, that'd be great. Here?
No,
No,
Are you guys able to hear?
no.
Okay, let me just look and see again. It's not giving me the option to share my volume. Sarah, so I think I'm going to skip this,
Okay,
and
maybe you
I'm
can
going to,
include it in the,
yeah, I'm going to put the link in the, or if somebody wants to put the link into the chat, and then you guys can watch it. He does a really great job of explaining the elements that need to be in place in order for racism to be an issue. That'll help us stay on time. But I do encourage you to watch it. It is funny as well as being really informative. So when I am out teaching people about racism in nursing, and my audiences are usually primarily white identifying nurses because most nurses are white identifying. These are some of the common things that I hear that nurses come up and say to me. Racism is not a problem anymore. A lot of nurses feel that because we had civil rights and some of these past really egregious laws like redlining and deeds saying that homes can't be sold to somebody who's Black or an immigrant, that those things are over and therefore racism isn't a problem. People are still experiencing generational harm from past practices, but also practices have evolved. So yeah, we can't have a public policy that says that we will not do loans for people based on their color or their racialized identity, but we do it anyway, right? If a recent news article, there was a Black family that their home was significantly underappraised. So they took all of the pictures and indications that anybody that was Black lived there, had their white neighbors sit in for their appraisal, and their appraisal was over $100,000 higher, right? So there's still practices, they just may not be as obvious if you're not experiencing them. I treat everyone the same. I used to say that when I was a nurse, and what I meant was in the emergency department, I didn't care if you were incarcerated or a CEO, right? I was going to do my job. But the reality is we have plethora of research, just piles for decades of research around health disparities and inequities, around bias and harm that happens. So we know we don't treat everybody the same. And in fact, when you look at Dr. Jones's points around how to achieve health equity, we must not treat everybody the same. So I'm an ER nurse. If I have two patients with DKA, and one is a 5-year-old child who's new onset and has insurance, has educated parents, one of the parents has diabetes and is familiar with how to provide care, and my other patient is a middle-aged person who lost their job and is now living in their car and doesn't have their health insurance and can't access insulin. The care and the plan that I need for those two people are vastly different. And if I were to treat them equally, one of them would do poorly, right? I also hear, I don't see color, or I'm colorblind. And I want to encourage people not to say that anymore. Because first of all, it's not true. I mean, some people actually are colorblind, but the reality is that we automatically categorize people when you look at them. That's something that we do in the way our brains are programmed. But when we say that we're colorblind, what we say is, I don't see you. I don't see your full humanity. I don't see what you're experiencing, right? So while race is made up, racism is not, and we need to see each other, and we need to have perspectives and understand what it is they experience. Most common is, I've been a nurse for X amount of years and I've never observed racism or discrimination. If that's you, then that means that your privilege is working. You don't see racism because you don't experience it, and you may not have people in your circle who do that can help you to understand it. And so you have to be especially motivated to learn. So I'm not seeing it. So what does it look like? And how do I see it? I had somebody recently at an international talk say, why don't you just call it inequity other than racism? We're really uncomfortable with this idea of racism, because I think when we think about it, we think about people with tiki torches and white hoods and burning down crosses, and that's not me. So I can't be racist, right? And So we're so anchored to this idea that we're caring individuals that we can't possibly explore that we're causing harm. And then I was doing a presentation for nurse leaders, and I did like a crowdsource. What do I really need to tell them? And I thought this was so poignant what this nurse wrote, and that is that I don't believe there's organizational racism. Racism is meanness in your heart that most people don't have. I believe it's unconscious, unintentional, without malice. It's a mistake. I believe most people are good in their hearts. This idea of being good in your hearts or being a nice person keeps us from being able to evaluate how we can improve ourselves as human beings and nurses and be able to provide good care. So what do we need to do? Ensure equity-minded nursing education. Campaign for Action, paired with AARP right now, is doing equity-minded nursing work. So we need nurses to be prepared to understand equity, structural, political, drivers of care, upstream knowledge, understanding how they impact social determinants of health. We need to build ethnocultural empathy. It's not a mean you're a bad person if you scored lower on that. It means you have some perspective taking to do, right? We need opportunities for diverse clinical experiences with appropriate guidance. I took over simulation a couple of years ago for pediatrics on a whim, right? Like the person was sick and I filled in. And they had two pediatric cases. One was a young boy. They were both identified by race. So this was identified as like a 6-year-old boy who was white, who was, had straight A's at school, and his parents were educated, and he had a appendectomy. And the other one was a Hispanic little girl who was about 8, and she had asthma, and her parents were undocumented and only spoke Spanish, and her brother was a gang member. I was horrified when I saw that. I mean, this just perpetuates stereotypes and inequities so significantly that I spent the first hour of that class saying, we're not going to use these scenarios because they're terribly racist and harmful. And these are the reasons why. And I had a couple of students who are part of the global majority. They're like, oh, I'm so glad you realized this was racist, right? But we need to look at what we're doing and how we perpetuate stereotypes. We need to shift to cultural safety and humility and a focus on dignified care, treating people the way we want our loved ones and ourselves to be treated. We need to learn bias mitigation strategies. So building allyship and accomplice skills. So I did put in the resources a self-assessment for allyship that people can use to see where you can learn and grow. We need skills in disrupting bias, and we need to see changes in our harm risk tolerances, right? It has to be as important to us that we don't allow our colleagues to provide biased care and harm them as we would with a medication error or any other type of harmful event. Other strategies, first and foremost, disrupting racism requires courage and it requires action. I made a promise many years ago that I would never be silent. I would speak up in any space when I saw bias, racism, harm happening. And I've been doing that for a very long time, and it is still hard because I often end up having to do that in rooms with people who I work with or I like or I don't want to have bad relationships with. So it takes courage, and you have to develop that. We need the perspective taking. We need to be able to see through other people's eyes, right? Because if I don't experience racism and I don't see it, I need to be able to see it through the eyes of somebody else who is experiencing it and understand it. We have to have a growth and learning mindset. We have to approach anti-racist work in nursing as an intervention and as something that we are constantly developing skills in. And we need to approach it with humility because you will make mistakes. I have made mistakes. I have said the wrong thing. I've done the wrong thing. And you have to be willing to hear that and take it in and learn and grow from it. We need to examine the standard of care when we're providing care, pay attention to the language that we shared. I included an article I wrote about stigmatizing language, and we need to build a culture where identifying biases is welcomed and that we're reflexive and able to evaluate our own biases. Like, imagine if at every handoff in any setting, right? Whether it's teachers handing off, nurses handing off, if in every handoff we said, what are the potentials for bias here with this person? Do we see any bias happening? Are their needs being met? Do we understand their needs? Are we providing culturally informed care like we do with other things that we hand off, how we might be able to achieve outcomes? So I wanted to give you guys a couple of sentences, but first I want to talk about private versus public. When nurses intervene or disrupt bias, it is often privately. So they hear somebody say something harmful in a room. They know one of their colleagues is harmed or a patient is harmed. And then privately they say, Anna, I felt uncomfortable with what you said. I think that might have been biased. And that's a step, right? But my personal philosophy is if the harm is done in public, the correction needs to happen in public. And here's why. So not long ago, I was in a room full of colleagues in a formal setting doing a roundtable, and one of the people directly across from me used the N-word. She used it in context of telling a story from when she was younger, but used the word hard R, and I was horrified. My face was red, my heart was in my throat. I didn't know how I was going to continue in that conversation. And the roundtable continued, and several nurses went on talking, never addressing that till it came back to me. And I had to address it. I had to say, there is never a context or situation where it's appropriate for you to use that word. You will never use that word in front of me again. And then later I had people come to me and say, are you okay? I'm really sorry that happened. I agreed with you. Then speak up. Right then. Don't tell me later that you agree with me. Tell me right now. Make it clear in that room that that language is not okay, that that behavior is not okay, right? Don't leave me hanging there. And also don't rely on the person who's most likely to be harmed to speak up. They're harmed. Speak up, right? And don't say, I think what you said harmed Anna, because what you're saying is that it's okay with me, but I didn't want Anna to get harmed, right? You need to speak for yourself. What you said was not okay to me, right? And that's hard, but we need to do it, because if later you go and talk to that person, if one of those nurses who maybe did go and talk to that person and said that wasn't okay, I don't know that. None of the other nurses know that. And that nurse thinks that everybody else in the room condoned what they said, right? So we have to address things publicly sometimes. So a couple examples of things that make it a little bit easier. And I know, Sarah, we're very close to that. I noticed this patient is not receiving the standard of care. Is there something unique I should know about them? This is something I teach my student nurses, because there's a big power differential, right, when they see bias. And so just reverting back to the standard of care allows people to first recognize, I'm not providing the standard of care, and second, go, why not, right? And sometimes that's based on explicit bias, and that's what you'll hear, and you can have a conversation about that. But there's some other examples here for you to look at. But again, speak from yourself. I'm not comfortable with what you said. Come from a place of inquiry. What made you say that? If you're getting biased information and report, I will often say, please keep your report objective. I want to form my own opinions. So there are some phrases that you can kind of practice and learn and engage in. So I'll let you guys read this. This is from Dr. Kamara Jones. Again, can't talk about health equity without her. That health equity cannot be achieved without anti-racism. So nurses have to adopt an anti-racist ideology and constantly be working to learn and grow. So the case study I try to keep really simple today. It is based on experience I've had in the last month. I posted that I was going to be doing this presentation, and I was attacked by two nurses who phenotypically look like they're racialized as white, about how this is ridiculous and it's harmful. And then they began attacking nurses who had pictures where they were melanated, telling them that they were a problem and they needed to get over themselves. And I just shut the whole thing down and report people. But that's where I drew this from. And I tried to make it relevant no matter where your practice environment is. So your department is notified you are required to attend mandatory DEI and anti-racism training. You get there, and at the beginning of the training, somebody who's an informal leader in the department says, this is ridiculous. Racism is not a problem. We have real problems that need to be addressed in nursing. People need to quit whining and get over themselves. This is a waste of time. Body language indicates that these statements have made some of your colleagues uncomfortable while others nod in agreement. So with this, what I want you guys to think about are, how does this department impact the department's culture, or the situation impact the department's culture and ability to address racism in practice? Who's harmed by the statement that was made? What strategies and statements could be used to address the statement in real time? Should it be done publicly or privately, and why? And how do you show up as an ally when you hear or you see racism denial?